Well, welcome everyone to the Western Regional Training Center and Health Services Research Seminar. It's a delight to have you all here. I'm not surprised at the size of the audience at the Regina end. Unfortunately, right now we can't see the Saskatoon end, but we will shortly. So welcome everyone, and for taking the time out of your busy schedules to come here today. We're going to be hearing from Dr. Carolyn Tuohy, who will be talking about healthcare hybrids, how other nations are changing the public-private mix, and what it means for Canada. Professor Tuohy has been studying Britain, the Netherlands, the United States, and Canada in terms of their respective health systems, in particular in terms of recent changes. And as you will note, as she will explain, there have been some major changes in Britain, Netherlands, and the United States, but not in Canada. Now, Professor Tuohy has had a long and distinguished career as a political scientist. After graduating from Yale University, she moved on to the University of Toronto. But in addition to teaching in the Department of Political Science there, she was also an administrator at the University of Toronto for a number of years. And in fact, she took on the role of Deputy Provost and Vice President, Government and Institutional Relations from 1992 to 2005. And what I understand from our earlier discussion, in fact, is she went in to do that role for 2 years, and she ended up for well over a decade. So she was really in addition to everything else, has a lot of experience with university administration. Her academic research has focused on comparative health policy, health systems research. I think many of you are aware of her classic work, Accidental Logics, the Dynamics of Change in the Healthcare Arena in the United States, Britain, and Canada, that was published by Oxford University Press in 1999. It's become a classic for public policy scholars, and not just those in healthcare, but those that are interested in historical institutionalism, period. In addition to that, she has written and published numerous articles in some of the top journals in the field, including Health Affairs and the Journal of Health Policy, Politics, and Law. She has also applied her knowledge in various capacities. She served as a member of the Board of Directors for the Institute for Clinical Evaluative Sciences, or what is known as ISIS in Ontario, as well the Canadian Health Services Research Foundation. She has also been an advisor to numerous other health organizations as well as governments. In fact, when the Romanow Commission began, one of the first meetings I had was with Carolyn at the University Club at the University of Toronto, and asked her what was probably one of the most difficult questions you could ask any scholar of health policy, which is, what is the one thing, if you could change anything, what is the one thing that you would change in the Canadian health system? And I think that during the course of her talk, she will allude to what has been one of the most difficult areas to change in Canadian healthcare, some of the reasons why it's been so difficult, and what the future might hold in that respect. She's currently Professor Emeritus at the University of Toronto, but that really doesn't describe her role, because she really works in a full-time capacity as Senior Fellow in the School of Public Policy and Governance at the University of Toronto, which is a fairly new venture and has become quite a successful venture. So on that note, would you all join me in welcoming Professor Carolyn Tuohy.
Thank you very much, Greg, for that generous and extensive introduction. It is a real pleasure to be here in Regina, virtually in Saskatoon, at a colleague policy school. So thank you very much for the invitation. As you can tell by the title of the talk, I'm going to be wading into some controversial territory today. I guess one can't really address issues of the public-private boundary, the public-private mix in healthcare, not only in Canada but in other countries as well, without stirring up some debate. We have deeply held values around our healthcare systems, not only in Canada but elsewhere, and a number of those values pertain to what the appropriate role of the state and the private sector should be. So let me tell you a bit, and I will, as a political scientist, I will be describing and explaining, but not prescribing, I think. I'll try to duck the question that Greg left on the table. What is the one thing that I would change? Although I'm sure you won't let me duck it forever. But what I will try to do is to tell you a bit about what is going on, particularly in the three other countries other than ourselves at which I've been looking, and how we understand some of the dynamics that are driving those changes. So, as a rough overview of what I'll be talking about, I want to take a few minutes at the outset just to look at in very aggregate terms, using some OECD data, what the impact of private finance on public systems is. In a few dimensions. General patterns, aggregate data. But then I want to spend most of the time drilling down to the four countries, and particularly the three non-Canadian examples. And even within that, a particular focus on what's going on in England and the Netherlands. I want to describe what I'm calling institutional entrepreneurs. A new breed of actor who is emerging in these systems, at least in some of these systems, and having very dynamic and unpredictable effects for good and ill. Although, as I say, I'll try to avoid that normative dimension for a while, but having very dynamic effects on the evolution of reforms in those systems. And finally, I'll try to draw some lessons for Canada. So first of all then, basic point, most of you are familiar with this, all OECD nations, Organization for Economic Cooperation and Development, advanced nations, combine public and private finance for healthcare to some degree. And this, don't worry in particular about reading along the bottom of the chart. I'll just show you there's Canada. These are arrayed in order of total health spending, even though the bars all total to 100% to show you the shares. I'll show you a slide in a minute that shows you the total levels of health expenditure as a proportion of GDP. And as you can see, there is a mix across OECD nations, and it doesn't particularly line up with how much nations spend overall. I'll come back to that, but at the high end of the scale, you'll see, of course, the US, the great outlier in all of these comparisons, is a very high spender in healthcare, on healthcare totally, and has a relatively small public share. But the next one, which is Norway, is also a high spender, but has a large public share. The right balance is a matter of debate, as I said at the outset. On the one hand, if we insist on public finance for at least a significant core of healthcare services, we're said to be denying the opportunity for choice, or denying the opportunity for individuals who actually are willing to take money out of their pockets and spend it on healthcare to do so. On the other hand, the arguments are made that allowing that sort of private payment will have negative effects, will have negative feedback onto the public system. So what is the evidence? And that's what I want to focus on today as much as possible. If nations spend more privately, does that allow them to spend more overall on healthcare? Well, not necessarily. Again, you can't read the nations at the bottom, but the labels at the bottom, but there's Canada, So you can see, as I said, at the high end of total healthcare spending, this is in purchasing power dollars per capita now, not percentage of GDP. The United States, of course, is a very high spender and also spends a lot privately. It's almost half and half now. It's actually more than half publicly if one considers tax expenditures, tax deductions for healthcare, which aren't included in these data. But then there's Norway and, as I say, down at the other end, the low spenders, a number of them, such as Greece, have a high public share. So no, it's not necessarily the case. If we look across nations, if we compare nations to each other, that spending more privately allows you to spend more in total. However, if we look across an individual country over time, if a nation starts spending more privately, does that increase its total health spending, or does it in fact crowd out public spending? This is a key question, and it's one that a couple of colleagues and I, Mark Staveley and Colleen Flood, looked at several years ago. Now, the data are old. They end in 1997, but what we found was that there was a marginal crowd-out effect. For every, we looked across OECD nations, and over that period of time, across 22 nations, what we found was, by looking within each nation at what was happening over time, for every $10 increase in private expenditure, subsequent public spending was about $1 to $3 less than you would expect. So think about that. There's an overall increase in spending, yes, but it's to some extent it's at the expense of public spending. So there's some marginal crowd-out effect. Interestingly, it varied across sectors. It was particularly true in the pharmaceutical sector. And we think that's because there's a heavy reliance on co-payments and playing with the level of co-payments in the pharmaceutical sector, and not so much true in sectors such as hospitals. Now, a key question for Canadians in the Canadian debate. Are nations that spend more privately on healthcare likely to have shorter waiting times overall or for publicly funded services? Well, the OECD did a survey in the early 2000s on national governments, asking them whether their systems had wait time problems or not. So it's just a dichotomous. Do you have a wait time problem? Don't you have a wait time problem? And when we look across those nations, it does not appear that it's private finance that's explaining the difference in waiting times. Those are the countries that gave the view that they had wait time problems or no wait time problems. And as you can see, the level of private finance varies in each category. And interestingly, if you look at the wait time problems, the Netherlands at that point in the early 2000s, was wrestling with wait time problems. It had a significant share of private finance, as you can see, but it organized its private finance, and I'm going to come to this point shortly, by sector of the population. So the lowest 2/3 of the population in income terms relied on public finance or social insurance. The upper third in income terms relied on private insurance. That's a very different model from the Australian system, the second in line there in terms of wait time problems, which relies heavily on co-payments, which is again different from the Canadian number 3 nation in the list, where we rely on a sectoral division. We fund hospitals and physicians almost exclusively publicly, and the rest in a very mixed domain of public and private finance. And similarly, if you look down at the other end, the US and Switzerland rely heavily on private insurance, but Switzerland does so in a heavily regulated system with heavy reliance on co-payments, and neither of them express problems with wait times. Neither, however, did some of the Nordic countries relying heavily on public finance. So, a long explanation of the chart to show that essentially wait time issues are systemic issues in these systems. They are complicated to deal with. They are much more complicated than simply infusing more private finance or, to be honest, more public finance into the system. That's Canada. So, let's look now beyond these aggregate data to how the public-private boundary is actually drawn in a number of these systems. Because what I've been trying to point out so far is that the sheer size of the public, of the private share, tells you very little about the dynamics of the system. You really have to look at how the system, how the border between public and private finance and public and private delivery is drawn. And let me emphasize those two dimensions. One is the role of private finance in paying for healthcare. The other is the role of privately owned facilities in providing services that are paid for publicly. This is a distinction that we keep making in the public debate, but it keeps getting lost. And we keep having debates about privatization, not just in Canada, but in other countries, that confuse those two issues. So this is where I had hoped that my laser pointer would work, but I will just direct you to this very rudimentary chart. Distinguish in your minds between the funding in the system and the delivery of services. Recognize that each can be either private or public. If looking at the funding column, private funding can take different forms as well. You can have co-payments in the system as your major share of private funding, topping up a public base. You can have a parallel private system that runs alongside the public system, as in the case of the UK, for example. Or you can have the sort of system that I was just describing in the Netherlands, which is based on covering different groups of the population. Some of them are covered publicly, some of them are covered privately. Go over on the delivery side, you can have publicly delivered services delivered by public agencies or by private agencies, which may in turn be for-profit, not-for-profit. If they're for-profit, they may simply be for-profit in the sense that they're owned by the practitioner, doctor, or they may be investor-owned. They may actually be listed on a stock exchange. These are very important distinctions, and they tend to get swept away in our debate about privatization. Moreover, there are multiple combinations, permutations and combinations possible in this chart in terms of how we bring together funding and delivery. So certainly you can have publicly funded, publicly delivered systems, services, as is the case for hospital services in a number of countries. You can have publicly funded, privately delivered services, particularly in the case of not-for-profit hospitals. Lots of countries organize their hospitals on a private, not-for-profit basis and pay for them publicly. You can actually have privately financed services delivered by publicly owned bodies. This is the case in the British National Health Service, in which National Health Service hospitals operate for-pay beds, private beds. So there are any number of permutations and combinations possible in this chart. Let me suggest, to simplify, 4 basic ways in which you can do this. 4 models that have become classics in the study of healthcare policy, and they tend to line up with different historical periods. The first type of healthcare state, if you will, was the social insurance model introduced in Germany in the late 19th century. Named after the German Chancellor Bismarck. The basic idea there initially was this would be a mechanism of funding through worker and employer contributions to social insurance funds or so-called sickness funds, which would then purchase services on behalf of the insurees. It became expanded to include more and more of the population. So that's publicly funded in the sense that these are mandatory contributions for workers and employers, so they're public in the sense, in comparative sense to public pensions in Canada, but they're privately delivered. They're privately delivered by separately organized physicians and to some extent hospitals, although many of the hospitals were state-owned. Then in the 1940s through the 1980s, the principal example was the Beveridge National Health Service model. That is the model in which the government owns and pays for. So it's publicly funded, publicly delivered. The British National Health Service is the poster child, hence Lord Beveridge, the British peer who gave his name to this model. The British system is the poster child of the publicly owned, publicly funded system. In the 1960s through the 1970s, actually Canada became the poster child for a new system, which was a single-payer system, funded through general finance, general taxation, and delivered through privately organized either physicians or not-for-profit hospitals. Not publicly owned, but publicly funded. And then finally, the sort of default model throughout all of this has been a targeted model in which essentially the private market, especially employer-based finance, is the norm, and government programs are targeted at certain groups that are deemed to be needy. The poster child there, of course, is the US, relying until recently heavily on, well, in fact, still relying on an employer-based system, but filling in with programs, government programs for the elderly and the poor. But again, even those government programs are publicly funded, privately delivered services. Okay, so different ways of combining these models. Now, what's particularly interesting, certainly for a political scientist, is the extent to which these classic models have been morphing over the past 2 decades at least. And so if we have here poster children for the Beveridge model, the UK, the social insurance model, the Netherlands, and the targeted model, the US, we see that in each of those cases, they have undertaken significant reforms to their system, which have had an impact on the way in which the public-private boundary is drawn. In Britain, the National Health Service hierarchy, which had existed from its founding in 1948, was broken apart in the early 1990s through the so-called internal market reforms. Health authorities at the local level, which had owned and operated hospitals and managed general practitioner contracts, were separated out from their ownership of hospitals. The hospitals were spun off as independent trusts, still publicly owned, but not-for-profit trusts. They were organized on a not-for-profit basis. And the purchasers, the health authorities, were no longer the supervisors or the budgeters for the hospitals. They had to contract with the hospitals as independent agencies. They became the purchasers. This was a huge upheaval in the NHS. This took an established hierarchy, a highly venerated hierarchy, by the way. We were told periodically, very often, and with truth, that Canadians, that Medicare is part of the Canadian national identity. And yes, there are polls that show this, that show it in terms of a symbol. It's right up there with the beaver and hockey and the flag. We know that. But we're not the only country that thinks it has the best system in the world and that really venerates it. I don't know how many of you watched the Olympic opening ceremonies in London, but if you did, you saw children jumping on trampolines that were meant to be hospital beds. It's a celebration of the NHS. So this venerated NHS in the early 90s then was split apart into purchasers and providers in a so-called internal market. The NHS, however, retained control through very significant monitoring and evaluation programs, which also went through various iterations. In the Netherlands moved over a 20-year period from the late 90s through to 2006 from the model I described, the social insurance model in which 2/3 of the population is insured through sickness funds and the upper third in income terms relies on voluntary private insurance, moved over a 20-year period to a model under which all insurers are organized on a private basis, but compete under common rules. Well, compete is too strong a word. Operate under common rules, under a common regulatory framework, and under a universal mandate. Everyone in the Netherlands must purchase private insurance, or must purchase insurance. The attempt to define what is public and what is private now in the Netherlands bedevils most observers, including those in the OECD. And if you track through the OECD data series over time, from 2004 through to now, you'll see them wrestling with what to count as public and what to count as private in this system. Half of the premium revenue in this system flows through the state and is redistributed on a risk-adjusted basis to the insurers. The rest flows directly to the insurers. How do you count that? Well, the OECD has decided we'll count everything, all revenue that is attributable to the basic compulsory insurance package, we'll count that as public. And so you'll now see the share of public finance in the Netherlands having taken a considerable jump up. You know, you have to put that into context in terms of what's actually happening on the ground. There's another reason it's taken a jump up, and that has to do with how long-term care is counted. So it's not entirely attributable to these changes. Anyway, so the Netherlands has moved from a social insurance model to what they call a managed competition model. As we'll see, competition overstates the case. The US has moved, and I can actually say this now. I had to live through, it's all about me. I had to live through the Supreme Court decision on the Affordable Care Act in last June. There were numerous state challenges and a challenge by the National Federation of Independent Business, who ended up giving its name to the case, challenges to the constitutionality of what is pejoratively known as Obamacare. So it survived that challenge. The individual mandate survived that challenge, and it has now survived the presidential election. So given that much of the program was not to be implemented until 2014, I think we can now say it is likely to be implemented by 2014, although there are many things the Republicans can still do to slow things down through withholding appropriations in Congress. In any event, given that that legislation is now the law of the land and is underway, its implementation is underway, the US is moving from a targeted model in which it relies predominantly upon employer-based private insurance supplemented by federal programs for a federal program for the elderly and a federal state shared cost program for social assistance recipients. It has moved to a complementary model. What the targeted model did was to leave a gap, was to leave about 15 to 17% of the population without insurance at any given time. At any given time. It's been estimated that some 27 to 30% of the population actually rotated through that non-insured status. Okay? But there was a gap that fell neither into the employer or the government program mix. That gap is now to be filled, or at least largely plugged, by managed competition among private insurance firms under a universal mandate, so something sort of like the Netherlands, for the small group and individual market. So if you are employed by a small employer, indeed if you're a small employer yourself, or if you're an individual and you don't qualify for a government program and you don't have employer-based insurance, you can go to an exchange, a health insurance exchange in your state, and you can find an insurer who carries the basic compulsory package. You can look at different prices. There are different tiers of insurance available, and you can be subsidized if you fall within a certain income cap. So that is meant to plug the yawning gap in US healthcare. It will not plug it entirely. We will probably only see something like 94% of the US population insured as this is fully implemented. That will vary considerably by state. Massachusetts has the model on which this was based, about 98% of the Massachusetts population is insured. So, in each of these cases then, poster child for one of these classic ideal types of the welfare state has now moved into this kind of hybrid territory of more independently organized purchasers and providers, in some cases competing, in other cases not, but all under a kind of regulatory umbrella. And in Canada. So we were the poster child for the single-payer system for physician and hospital services, and we are still the poster child for the single-payer system for physician and hospital services. We have made very, very few changes to the fundamental architecture of our system in terms of the public-private boundary. We've done other things, but in terms of the public-private boundary, we've made very few changes. What has happened is a kind of passive privatization, it's been called, as services that used to be delivered in hospital move outside the hospital, principally through advances in drug therapy. And of course, drugs fall into a much more mixed category of finance that varies across provinces. So we have a system which is actually the most exclusive in the OECD, the strictest in the OECD, in the physician and hospital sectors in terms of the insistence on public finance. But for all other services, we are in US-style territory of targeted governmental programs. This varies across provinces, and there have been changes in that area. But relative to these other national examples I've given you, we have stayed with, put it that way, we have stayed with the architecture of public and private finance and delivery that we started with in the 1960s, or that we underwrote in the 1960s when Medicare was enacted, in the 1970s when it was fully implemented. So, across all of these countries, including ourselves though, we see commonalities. And one is this, and this is a really central one. How do we develop a sophisticated purchasing function in the healthcare system? This is a kind of more gentle way of saying, how do we control the power of providers in healthcare? And each of the examples that I gave you in the UK, the Netherlands, and the US were, well, the UK and the Netherlands in particular, were aimed at creating a sophisticated purchaser that could operate on a more equal playing field with providers in terms of getting value for money. And to some extent that's true in the US, I'll get into that. But essentially there are three models for, three locales, three venues for the sophisticated purchasing function. One is physician-based, that's the UK model. And pretty much from now on, I'm going to start talking about England, because we're going to move into the 2000s. Let me just put a little footnote there. In 1999, authority over health, social services, and education was devolved in the United Kingdom to Scotland, Wales, and Northern Ireland. They went in quite different ways in healthcare than England did. England stayed very much with the internal market model. There's a very interesting story to be told about the others, but in the interest of time, I'm going to be focusing on England, which is, of course, by far the largest of the 4 countries in the UK. England went with a physician-based model of sophisticated purchasing. The Netherlands is experimenting with an insurer-based model. A couple of other, just to round out the possibilities, I will note that Australia and New Zealand, particularly for the purchase of drugs, have a fairly sophisticated government-based model of purchasing. But again, in the interest of time, I'm not going to be talking about that. I will focus here on the UK and the Netherlands. And I must preface this by saying each of these is in the process of evolution. So if I come back here next year, I may have a somewhat different story to tell you. I doubt it, frankly, but they are evolving. There are some common threads and themes across these various models, however. One is to the extent that you decentralize purchasing, as is the case in the UK and the Netherlands, decentralized either to physicians or to various insurers, you have to deal on the funding side with the fact that there will be an incentive, there may be an incentive to reduce your costs by serving healthier people, right? You have to guard against the risk selection incentives in the system. That requires very sophisticated risk adjustment. Well, we used to think it required very sophisticated risk adjustment formulae. What the Dutch discovered was that the risk adjusters, principally government regulators, don't need to be perfect. They just need to be as good as the insurers. They just need to know as much as the insurers do about the risk profiles of the people that they're insuring. And that was kind of a breakthrough in the Netherlands, and it allowed them to make real advances on the risk adjustment formula, largely by looking at what the insurers were doing. So risk adjustment, though, risk-adjusted population-based funding is true whether you're decentralizing to physician groups or whether you're decentralizing to insurers. Another key, and this has been the case both in England and the Netherlands, patients still trust providers. There's been some erosion of trust in providers, just as there has been in all kinds of social institutions. But still, physicians, nurses are trusted way more than insurers and government officials across these nations. And so engaging physicians, regardless of whether you've got a physician-based model or not, engaging physicians in sophisticated purchasing is crucial. And then I'll also say something about the ongoing debate about the importance of competition amongst providers. As, in other words, can you really have sophisticated purchasing if the purchasers don't have a choice of provider? So how important is competition amongst providers? Okay, let me tell you a bit about what's going on in Britain. One of the most interesting things about developments in Britain is the emphasis on general practitioners as purchasers. This builds on an existing strength in the British system, which has had population enrollment with general practices since the inception of the NHS. This is not a new idea. Enrolled populations with primary care practices is an old idea in the UK. And those practices have involved non-physician practitioners, in particular nurses. And they have been linked over time, although this has varied, to local authorities, and therefore they have a population planning link. So there's a base to build on. This is very important to keep in mind and think about what the extent to which such a base exists elsewhere, including Canada. In the 1990s, as part of the internal market reforms that I described, a relatively small feature was so-called GP fund holding, giving general practices a budget, a real budget, devolved from the health authority to purchase a range of hospital and community services, about 20%, on behalf of their patients. This was an innovation in the British context, and it was popular, well, we'll come to this, but popular beyond expectations with both GPs and patients. However, when the Labour government came in 1997, the Labour government the Labour Party had been vitriolically opposed to the internal market reforms as a commercialization of healthcare. They abandoned all language relating to competition, contracting, and adopted very different language about collaboration and commissioning, but they kept the purchaser-provider split. However, they did away with the GP fund holding model for reasons I'll get to, and established universal primary care trusts, which were the successors to health authorities and which worked in cooperation with local committees of general practitioners. Now, the legislation passed last March brings general practitioners back to the center. There are to be GP-led clinical commissioning groups, CCGs, which are consortia of general practices. So as a general practice, you are required to be part of a consortium. The boards of the consortia, however, represent specialists, consultants in the UK language, and nurses. And those clinical commissioning groups will spend about 60% of the NHS budget. They won't commission GP services because that would be a conflict of interest, but they will commission hospital and community services. And they will be linked to local authorities through bodies called health and well-being boards. So that's a brief summary of the the changes related to the purchasing function in Britain. The insurer model in Holland, as I said, the Dutch moved from sickness insurance, social insurance model through to a private insurance, if you want to call it that, scheme in 2006. The first step in doing so was to abolish the regional monopolies that the sickness funds had held. There were assigned sickness funds for particular areas, and they had to contract with all of the providers in their region. That was how it worked. So that was abolished in the mid-1990s, and they were allowed to compete with each other on a nationwide basis, the sickness funds, and they were also allowed to selectively contract with providers. This was a major change in the Dutch system. There was considerable, and actually this is quite surprising given how solidly entrenched the previous system had been, considerable enthusiasm amongst the social insurers about this change once they got their feet. Some of them just left, exited the field. But others became quite entrepreneurial in ways that I will discuss a little bit later in the talk. The selective contracting is still under essentially fixed prices, although the hospital sector is being progressively deregulated in terms of price. And so far, although this is changing and changing quite rapidly, the insurers are negotiating with providers largely around the price in that deregulated segment, rather than in terms of quality of services. But increasingly, we're seeing insurers taking an interest in the quality and in inserting mechanisms into their contracts with hospitals in particular and primary care practitioners that have quality metrics. All of this, however, and this is really important to know about the Dutch case, is underpinned by a strong commitment to solidarity. This is a fundamental value in the Dutch system. And therefore, there has been all kinds of buffering against the assumption of risk by insurers, against opportunities for profit. In fact, it's very difficult to make a profit as a for-profit entity in the Dutch system. Most are, in fact, organized technically on a not-for-profit basis. And again, I'll come back to that point. Another key point about Holland is that the adoption of information technology was absolutely key in bringing these reforms about. And it was done with the enthusiastic initiative, really, not just acceptance, but initiative of physicians. It is, as I said, still a work in progress, and particularly a work in progress on the physician side. These reforms have focused on the insurers, as I said. Now, what I want to do in the remaining part of the talk, and Greg is going to give me the high sign when I'm taking too long, is just to flag the role of what I'm calling institutional entrepreneurs in each of these cases, in England and in the Netherlands. We're familiar with the concept of an entrepreneur in the private sector. Okay, an entrepreneur takes risks in combining capital, labor, and technology to meet the needs, to meet a demand from some set of consumers, and to make a profit. Political scientists like me have been trying to develop an analogy to the concept of the economic entrepreneur by thinking about, are there public policy entrepreneurs or political entrepreneurs, thanks, Greg, who also combine resources in different ways, but they link problem definitions and policies and political support. It's a much looser use of the term entrepreneur, quite frankly, and it's a little difficult to pin down. Well, what I'm interested in is an institutional entrepreneur who works across the public and private boundary, hence the relevance to this talk, who combines a public mandate of some sort with resources in the private sector to create new value for some set of consumers, and to profit in some way in terms of, and sometimes financially, sometimes in terms of reputation or career advancement, sometimes in terms of professional standing. So institutional entrepreneurs combine public mandates with either private capital or professional expertise, essentially private sector resources, or both. And so let me give you a principal example here of what I consider to be an institutional entrepreneur, and that is those are the entrepreneurial general practitioners who responded to the GP fund holding option in the UK. As I said, it was introduced as a relatively minor aspect of the reforms. It was the brainchild of a couple of policy entrepreneurs. It combined a public mandate to purchase, so these GPs were given public funds which to purchase, and a public mandate to purchase, with the professional expertise, the clinical expertise of the GPs themselves. And as I said, this became popular with GPs and with their patients beyond expectations by 5 years after the first fund holders were established. By 1997, more than 50% of GPs had taken up the fund holding option. And they were beginning to develop all kinds of different models of fund holding, bringing together groups of practices. Now, that also, interestingly enough, galvanized opposition amongst other GPs who saw this as creating two-tier medicine, because it was becoming clear that patients of fund holders were actually somewhat better off. They were getting, because the GP fund holders could contract with hospitals, sort of in competition, in a way, with the health authorities. They could contract with hospitals. The argument was that patients were getting better access, they were getting better quality, in the sense that the GP fund holders were demanding quality metrics, even on this, relatively small portion of hospital services that they were contracting for. And so there was significant opposition that this was introducing a two-tier element into the NHS. And so a kind of opposition group of entrepreneurial GPs developed, who established a different model of so-called locality commissioning, in which they worked closely with the health authorities. They didn't have real budgets themselves, they had so-called indicative budgets. They were given hypothetical budget to work within and advise the health authority. Anyway, they both became politically active, both the fund holders and the non-fund holders. They established their own political associations and they became very active with politicians. And they continued throughout the period of the Labour government to be politically active. Even when Labour came in and abolished fund holding and established primary care trust, they continued to press. In fact, the non-fund holders were very happy about the move to, initially very happy about the move to primary care trusts that were advised by professional executive committees of GPs, because that looked exactly like the locality commissioning model that they had been promoting, the health authority advised by a group of GPs. But that became a more and more unwieldy model in their mind. And they also, both sets worked with politicians on both sides of the House, most notably with the conservative shadow critic, Andrew Lansley, who became the health secretary after the 2010 election, to push for returning GPs to the center of purchasing. And that's exactly what happened with the 2010 legislation that establishes these clinical commissioning groups. So in other words, that just indicates that the two groups, the fund holders and the non-fund holders, established a coalition in support of these reforms. These institutional entrepreneurs, I argue, took GP commissioning from a marginal reform in the 1990s through to the center of the policy framework, even though they weren't involved in the detail of design of the program. You know, given the time, Greg, I'm going to skip over what I have to say about foundation trusts. If any of you are interested and know anything about the model of foundation trusts on the hospital side in England, feel free to ask me in question period. There are more entrepreneurs in the hospitals in this foundation trust model that gives some greater autonomy. And I will have to skip over the evaluation as well. So these reforms have also brought forth a variety of other types of providers. For-profit providers, the so-called independent sector treatment centers. This was, interestingly enough, a Labour government innovation in 2004 to establish independent sector treatment centers, which could be for-profit, which are essentially specialized clinics and would operate under contract with the NHS, and they have been further encouraged under the coalition. They really didn't take off to the extent that they were expected to, even though they were given a premium of 11% above the standard payment to enter the field. There are other for-profit investors, investor-owned examples, however. There's a group called Care UK that began with long-term care homes and has now taken on a number of other contracts under the NHS. There is a very interesting hybrid example, which is this Circle Partnership, which is actually operating an NHS hospital now. It is 51% investor-owned and, well, 51%. And 49% employee-owned. Sorry, those don't add up, do they? It should be 50. Which began in the private sector, but presents itself as essentially a social enterprise. It says it's essentially employee-owned. It's pretty controversial, and it is operating. It is the first time that one of these for-profit groups or proprietary groups has been given a contract to fully operate an NHS hospital. It's being very closely watched. If anything goes wrong in that particular example, it will have ramifications well beyond the particular Hinchcliffe Hospital, which is the one that's being run. There are also examples from within the medical profession itself. There was a group of GPs in Louth who took over a failing hospital, another in Devon that brings together alternative medicine practitioners and physicians. But I will skip over this quickly. The evidence of on the impact of competition in the UK is particularly interesting. Carol Proper is a health economist at Imperial College in London, has done some terrific work both in the 1990s when hospitals actually competed on price for contracts with health authorities, and in the 2000s when they had to follow a fixed price, a fixed tariff. They could only compete on qualities. And what she and her colleagues found was that competition under variable prices, competition on price, in other words, was associated with decreased quality in terms of readmission rates, for example, after heart attacks. Whereas competition under fixed prices was actually associated with increases in quality. This is something for Canadians, I think, to pay considerable attention to. In the Dutch case, the entrepreneurs were the social insurers, the liberated social insurers who were sprung from their regional monopolies to compete nationally. What they did was to take their public mandate, that is to say, it was mandated that you have social insurance if you were below a certain income category level, but they began acting much more entrepreneurially. They began, because they could compete nationally, they merged with various private insurers, they established highly complex corporate structures. What they were about was increasing their market share, interestingly enough, both sickness funds and social insurers. As I said, it was really hard to make a profit, a financial profit, on the compulsory basic package, but if you could increase your market share, you could upmarket other lines. You could market supplementary health insurance, you could market life insurance. So there's a big struggle for market share. And what that did was end up with a much more concentrated, well, it exacerbated a trend toward concentration in the insurance market that had already been going on. So in fact, the Dutch system is arguably no more competitive than it was when there were regional monopolies, or very, very slightly more competitive. So that was one anticipated consequence, the concentration. But there were interesting upside effects as well, and that was the investments in information technology that were driven by this shift. It created an enhanced potential for risk selection, choosing healthy patients in the first instance, but then government regulators caught up relatively quickly by watching what was going on and requiring reporting. Let's talk about the US in question period. So an overall assessment of entrepreneurial impact, it's very risky, it can't be predicted. You're more likely to get entrepreneurialism on the provider than the purchaser side, which has generated an imbalance in these systems. That's been true in the UK. If I'd been able to talk more about foundation trusts, I would have emphasized that. So the purchaser side is playing catch up in this regard, but it is playing catch up. The key will be whether these developments can, in fact, galvanize a sophisticated purchasing function, whether enough, for example, in the UK, enough general practitioners will embrace the model. It's one thing to have 50% of excited volunteers, 50% of the GP population as excited volunteers. It's another thing to have 100% of conscripted GPs in the model. So we'll see how enthusiastically it's embraced and practiced. Implications for Canada. Part of what has kept us so stable, or a kind of counterpart to our stability in terms of the public-private architecture, has been that there have been very few footholds for entrepreneurialism. Why is that? Because the design of the single-payer model, because it is restricted to physician and hospital services, and because it is so exclusive in its design, draws the medical profession, in particular, into an alliance, if you will, or a bond, with the provincial government in each province as the political core of the system. Neither has an alternative. The governments are committed to exclusively funding the profession. The profession has no other payer to which to go. And so that has been the political core of the system, and increasingly issues of system design have come down to that central negotiating table, which has generated over time reasonably good remuneration outcomes for Canadian physicians in international comparison, periodic freezes and caps, but over time. But it has allowed relatively few entrepreneurial footholds. We have seen entrepreneurialism in the Canadian system. We can talk about some examples later, but there's very little opportunity to diffuse it when that central negotiating table is the key political driver of the system. So one of the areas in which we can see our lack of entrepreneurial take-up is in the use of EHRs, electronic health records. There is Canada. This is a Commonwealth Fund survey as compared, for example, to the UK. I would describe this as a pretty abysmal record in international context. The Commonwealth Fund just released another study yesterday or earlier in the week. We have gone up, this primary care physicians have gone up now to 50% who are using some electronic health records, but we still have not caught up, and others have moved up even higher. So they added Switzerland actually in this most recent survey, and that saved us from being dead last, but otherwise we would be dead last in the current survey as well. So, possibilities for incremental change in Canada. I believe this is my last slide, Greg, so you'll be pleased to know. Double check that. Yes, it is. Okay. So what are the prospects, given what I've said, for entrepreneurially driven change in Canada without a broad system reform? Are there any footholds in the system that we could look to? And would we want to? That's another issue. So actually, we already have our providers independently organized. The UK had to create this, right? The UK had to create a purchaser-provider shift split. We've got it. We do have variation across provinces. So there's lots of potential, in theory at least, for entrepreneurial experimentation that differs across provinces. We can learn what works, what doesn't, what the pitfalls are. And here's my final point. Since payment mechanisms are at the core of the single-payer system, that's where we need to look to for the possible diffusion mechanisms. We've seen some of this in primary care reform, moving to different remuneration models and negotiating it through the central bargaining table in each province. It's been very slow, and it's been hostage to the protection of a fee-for-service pot. We've seen movement in the hospital sector, from global hospital budgets through to more volume-oriented mechanisms. But again, it's been slow. These are the kinds of models, though, that have provided platforms for entrepreneurs in other jurisdictions, and I'm really eager to get the details of the current Ontario deal, the deal that was just announced this week between the Ontario government and the Ontario Medical Association after a really fraught negotiation that involved threats of legislative freezes and court challenges. And over the summer, behind the scenes, they actually were working on a deal which does indeed involve a cap. Now, we've been there before. We've all been there before. We've all had global caps on the physician budget at some point. This is another global cap. But it's worked out on a more, as far as I can gather from the press, and that's all I've seen, on a more granular basis, where physician groups have actually drilled down and looked at where they can make so-called efficiency gains in order to stay within the cap and still retain the fee levels at the levels they've been insisting on. So we will see whether these utilization changes, with the concurrence and the active involvement of the profession in design, actually make a difference. We may, in fact, see then footholds for entrepreneurial change and diffusion if that sort of example works and is replicated elsewhere in Canada. It is being closely watched, and we have a lot to learn from other jurisdictions. That's the formal part of the talk, Greg.